another study from a different author, same thing. This was, once again, monthly measurement of diffusion, random water in normal occurring white matter MS. So over a period of months, you see prior to the onset of a new lesion, a steady worsening, a steady decrease in the amount of diffusion. This is nice. This is comparing the amount of perfusion to neuropsych testing. And what this shows is there's a clean correlation between the amount, the poor perfusion and poor cognitive performance on neuropsych testing. Okay, so then what's going on? Why is, so we know that it's not the autoimmune therapy's fault, the drugs don't work, the oligodendrocytes are dying first, there's abnormal poor perfusion and diffusion in the tissue around these oligodendrocytes. Why is that? So now let's talk about venous. The term venous hypertension would be a synonym for CCSVI. In a sense, CCSVI is a Doppler definition, right? Dr. Zamboni defined it as a certain criteria based on Doppler. So we always kind of run into that problem. This was a very interesting guy who came to the conference in Bologna, a real character. He's a bioengineer, so he looks at the world in this way. And so basically, in his way of looking at it, this is what a stenotic vein, this is stenosis. So, okay, what's going to happen when you have stenosis? So he's developed a mathematical model of it. So you have your arteries coming in, you have the sinuses leading to the internal jugular veins. So here would be the inferior jugular veins. This would, in this way you think of it, here would be the sigmoid sinus, the transverse sinus. Here's the straight sinus. This is the superior sagittal sinus. So he said, let's just look at this as a straight mechanical model. What comes in has to get out. What's coming there has to equal what's going there with the addition of cerebrospinal fluid. So in the choroid plexus, maybe some of the flow that's coming into the artery, maybe it's going out through the CSF. Though in fact we have not shown that there's an abnormality in that, but it still ends up having to go back in. It's not really leaving the system. It's still got to go. It's still staying within the system. So that there's going to be a steady decrease in pressure as you move from the arterial side. And then notice that he actually put in room for shunting, right? So that blood can go the route it's supposed to go, but it can also shunt. It can go around the route it's supposed to go. So as he did this mathematical, essentially mental exercise, he walked through, if you have a problem, stenosis in the jugular veins, what's that going to do going back up through the system? So left ventricle arterial entering the brain, and then going into the cerebral sinuses, and then leaving. And so he worked through where you would find that abnormality. This is work that we're really going to figure out a way to measure. How are we going to measure pressure in these very small vessels, thalamostriates, and for instance. This is Bergen. Bergen wrote a review article. He's retired. He was UCSD. He wrote the review article in the New England Journal of Medicine on chronic venous disease. And so he went through this. I want to spend a little time on it. So a key factor is you want to have essentially laminar flow, but you also want to have what you call vortical flow, because this pattern keeps the vein healthy. You want to have a sort of a steady flow that keeps the vein healthy. If you don't do that, and I think I saw this slide before, and it was a nice color version, so I don't know why I got a lousy version. But so with normal laminar flow, shear stress sounds like it should be bad. It's actually good. You want the stream, you want the Mississippi going down straight. You don't want it turbulent. You don't want eddies on the side. You want it going down nice and smoothly. If you don't, if you get flow reversal, if you get reflex, then bad stuff happens. Bad stuff leading to promotion of migration. So you basically end up getting inflammation. So what the venous guys have figured out over 20 years, especially in other parts of the body, is that you want good flow. If you don't have good flow, you're going to get inflammation. Not on an autoimmune phenomenon, but on a mechanical basis. So in this same article, he goes through what the risk factors are leading to venous hypertension, leading to venous dilation, valve distortion and leakage, altered shear stress. These lead to inflammation. Hypertension, venous dilation, valve distortion, without any autoimmune theory involved, leads to inflammation. The inflammation then affects the valves, causes chronic reflux, and then you get capillary hypertension, capillary leakage, and more inflammation. So this was, in general, peripheral venous disease, but it's the same. And so I want to read you one more kind of long piece, because when you read it, you don't read it, but I'm going to read it. It just sure sounds familiar. Despite the diversity of signs and symptoms associated with chronic venous disease, it seems likely that all are related to venous hypertension. In most cases, venous hypertension is caused by reflux through incompetent valves, but other causes include venous outflow obstruction. An analysis of cases of chronic venous disease indicated that primary valvular incompetence was present in 70 to 80%, and a congenital anomaly in 1 to 3%. The valve abnormalities include stretching, splitting, tearing, thinning, adhesion of valve leaflets caused by inflammation of valve leaflets, and the venous walls by monocytes and macrophages. Histology studies found hypertrophy of the vein wall with increased collagen content, disturbed collagen synthesis, resulting in overproduction of collagen type 1, reduced synthesis of type 3. The acute effects of increased venous pressure have been studied in animal models. Although the valves were stretched immediately by the increased pressure, reflux did not occur until at least 2 days later. After 3 weeks, the number of granulocytes, monocytes, macrophages, and lymphocytes were increased in the pressurized valves, and MP2 and MP9 levels were raised. Morphological changes in the valves also occurred. There were reductions in leaflet height and width, and some valves disappeared. Leukocyte rolling, adhesion, and migration, as well as microhemorrhage, parenchymal cell death, were all increased at the high pressure site. Venous valves are operated by pressure rather than by flow-driven devices, so that little or no reflux is needed to bring about complete closure of the valve. Flow through a valve separates an approximately directed jet and vertical flow in the venous pocket behind the valve cuffs. The vertical flow prevents stasis in the pocket and ensures that all surfaces of the vein of the valve are exposed to shear stress. Low or zero shear stress, disturbed or even turbulent flow all promote an inflammatory and thrombotic phenotype. It is not known what initiates the inflammatory events in venous valves and walls. Overall, it appears that inflammatory processes involving leukocyte endothelia interactions and triggered largely in response to abnormal venous flow are important in causing adverse changes in venous valves and vein walls. Leukocytes accumulation is largely due to leukocyte adhesion to, as well as migration through the endothelial small vessels, especially postcapillary beacons. Increased expression and activity of MMP and PIMP, the extravasation of red cells leads to elevated levels of ferritin and ferric iron. This increase may cause oxidative stress, MMP activation, and the development of a microenvironment that exacerbates tissue damage and delays healing. So this was written in 2006 before this whole CCSVI began. And it just sounds exactly like what we've been hearing about for the last year. We don't need another explanation. The chronic venous hypertension literature offers us almost everything we need to explain these disorders. Mark talked about this. I thought I might spend time on that one. Okay, so basically what I am saying is these guys are dying first. Myelin debris is falling off the axons. First microglia are in the brain, and then macrophages, which are not part of the autoimmune process. They're just simple scavengers, are coming in to clean up the mess. So what about the blood-brain barrier? So there's your epithelials. This is an endothelial cell. This is the endothelial lining. Endothelial lining has tight junctions.